Good afternoon and welcome to today's webinar titled Autism Care Demonstration, Program Changes, an overview of what TRICARE beneficiaries need to know. This webinar will provide an overview of the comprehensive changes to the Autism Care Demonstration Program. Learn about changes to the program, including new program improvements for parents and families. We're thrilled to have with us today Dr. Amy Serta and Dr. Christina Biena. Dr. Serta is a behavioral health and autism care demonstration nurse consultant at the Defense Health Agency, and Dr. Biena is a clinical psychologist, autism care demonstration clinical lead, and senior policy analyst at the Defense Health Agency. Without further delay, I'll turn things over to Dr. Serta.
Thank you, and thanks for joining us today. We're thrilled to share information about the recent TRICARE Autism Care Demonstration policy changes. And this is something we are very passionate about and always appreciate the opportunity to share information. So the appearance of hyperlinks does not constitute endorsement by the Department of Defense of this website or the information, products, or services contained therein. For other than authorized activities such as military exchanges and morale, welfare, and recreation sites, the Department of Defense does not exercise any editorial control over the information you may find at these locations. Such links are provided consistent with the stated purpose of this Department of Defense sponsored webinar. This webinar will provide an overview of the comprehensive changes to the Autism Care Demonstration Program. Learn about changes to the program, including new program improvements for parents and families. So this will be the agenda for today. We'll do a quick overview of the introduction to the Autism Care Demonstration policy changes. We'll discuss what's changing, some of the exclusions, additional contractor responsibilities, provide an implementation timeline to give a visual of some of these changes, go over some TRICARE resources, and an opportunity for Q&As. So the Autism Care Demonstration began July 25th, 2014, and we've learned over the past few years through stakeholder input, literature and research, talking with commercial and Medicaid coverage plans, and through our government oversight and the lessons learned, where we're at today. So these changes were a collaborative process that involved all of what I just mentioned, and we wanted to shift the focus to a more beneficiary-centric model. So the ACD is authorized to provide the clinically necessary and appropriate applied behavior analysis services, or ABA services, for the diagnosis of autism spectrum disorder. And I emphasize clinically necessary, and we're going to talk about that a little bit more today. We want to see providers rendering the active delivery of ABA services. And as we go through these changes, you'll see the beneficiary eligibility and how we've kind of incorporated these changes to really focus on the beneficiary and their family. And that's over to you, Chris.
Excellent. So I'm going to start with the eligibility changes or streamlining of those requirements and improvements. So they really, again, like Dr. Serta mentioned, they are for the intended purpose of making it easier for families to get access and earlier services. Again, we're looking for early diagnosis, early intervention, and many of these changes align with that effort. So we, first and foremost, expanded the approved list of diagnosing providers. Previously, we had the primary care folks, the select primary care folks, and then we had a specialty list, which what that meant was if you received your initial diagnosis from primary care, then you were required to follow up with a confirmation diagnosis. That's a 1 year, but no later than the 1 year mark. So we've removed that confirmation diagnosis and expanded who can diagnose. So again, making it easier to get access to clinically necessary services. We still think that it's really important for our families to meet with those specialists as they have specialized training. Remember, the developmental behavioral pediatricians or clinical psychologists or maybe even child neurology, those individuals have specialized training and can speak to many of the other options, many of the other potential either treatments or things to consider when first diagnosed or through your treatment process. Those are critical folks with whom to have conversations. There is a clarification added in this change that if you are first diagnosed after age 8, so, early ages, no diagnosis, or there was a delay in diagnosis, that one will have to come from the specialist, and those are spelled out, those requirements are spelled out. But again, we're trying to get everybody early diagnosis and early into services. Okay, so for tracking purposes, everybody may recall or may have known this, but so when you get a diagnosis, the provider submits a referral, and then every 2 years there was a requirement for an updated referral, or for continued services, you would have an updated referral. And that used to be contingent upon the number of authorizations of ABA services. So the previous requirement was after 4 consecutive authorization. So after 4 6-month periods of ABA. Now we've streamlined it to just a calendar 2-year mark, so that wherever you are in the process, that 2-year mark from the initial diagnosis will trigger a new referral. Also streamlined were the outcome measures. There were various requirements to get the outcome measures completed prior to this change. The first and foremost was the requirement of the specialized ASD diagnosing provider to complete those outcome measures. We have removed that requirement, so now contractors will utilize all appropriate providers who have the training or accessibility and oversight to administer those. So eased that process, so not solely dependent on the specialist, but to get those outcome measures done, so they'll be required at baseline, so prior to issuing the treatment authorization, which means anytime from that first diagnosis through that initial process, you can get your ABA assessment going, you can get some of these other components going, but those outcome measures will need to be completed before ABA starts. And again, we've expanded who can complete those measures. I'll be talking a little bit more about outcome measures further down, but I just wanted to mention the aligning of the timeline. The other element that we changed with the outcome measures is the cycle of the outcomes. So at baseline, which I mentioned that change, but then also at the 6 and 12 month interval. It used to be every 2 years. And with that specialist doing that confirmation diagnosis, we had the up to 1 year opportunity to get outcome measures done. But there were a lot of folks who were getting them done at the end of that cycle, and then that next cycle would already be starting. And so again, these are meant to streamline, have clear benchmarks where things are tied to authorizations and referrals. So again, easing of that requirement. What hasn't changed is that active duty families are still required to be enrolled in your EFMP program as well as registered in ECHO. The change is that ECHO historically had an additional 90 days in case there were issues or challenges with completing the paperwork. We found that there were very few exceptions or very few situations where families requested something beyond the original 90 days. And so to align with the regular ECHO benefit and the provision and the guidance that's under, we streamlined to be in alignment. Here we are on ACD authorization. So as of August 1, so in roughly 45 days, that change to the outcome measures, like I mentioned on the previous slide, will be required at the time of that request, right? So before the next authorization is issued, those outcome measures will be required. The other change is, or streamline, is that ABA services, to be reimbursed, the treatment plan needs to be reviewed and authorized prior to rendering of reimbursable services. And what that means to the family is that your ABA provider needs to get that paperwork in, that treatment plan update into the contractor on time so that there are no gaps in reimbursable care. Late submissions will risk gaps, but remember, that doesn't mean services stop. It just means that there's no authority to continue reimbursing for that. And we encourage you to help keep track. I know the ABA providers are really good at that, but help stay on top of getting those submissions in so there are no gaps, or at least minimal gaps if there happen to be.
Thank you, Dr. Viana. So Autism Services Coordination, this is where this Autism Services Navigator, or the ASN, comes into play. And this is really a critical piece to this change. This ASN will become effective. The requirement starts on October 1st, 2021, and they will be provided to all new beneficiaries entering the ACD. So let me define what a new beneficiary would be. So that would be anyone coming into the program not currently receiving ABA services under the ACD, or if for some reason they had a gap in ABA services greater than 12 months. It would not apply to somebody, say, PCSing. We have a lot of movements in the military health system, so it wouldn't be if you were in the East region and you PCS to the West region, you would not be considered a new beneficiary. And to clarify, this requirement only applies to beneficiaries enrolled in the East and the West regions. So if you are enrolled to, say, the TRICARE Overseas program, or any of the U.S. family health plans, or even TRICARE for Life, the ASN requirement is not a requirement in those areas. Just so I can point out, because we had a lot of questions come in about this after previous webinars, that the ASN is employed by the contractor. So they would be employed or subcontracted by either Humana Military in the East region or HealthNet Federal Services in the West region. The Autism Services Navigator's role. So the ASN role will be to collaborate with all stakeholders for the beneficiary, and they're really overseeing the assessment, planning, facilitation, care coordination, and evaluation. To me, it's really a step up from case management, and that you're really getting that whole care coordination effect. So they're also the primary advocate in the healthcare setting for the beneficiary and the family, and they'll be the primary point of contact. So if you have questions, you'll have somebody on the contractor side, your ASN, who can help you. They also may be assisted by a non-clinical outreach coordinator. So the assistant may be a non-clinical person, but I want to point out that the ASN does have to be we have a series of credentials and experience with autism or behavioral health. They have to be nurses, social workers, psychologists, so it is a clinical person. So what can you expect from the ASN? So this will be the person that makes the first contact with the beneficiary of the family once the referral to the ACD or ABA services has been placed. They'll develop a comprehensive care plan, and we'll talk a little bit about that more on the next slide. They'll coordinate the medical and behavioral health services, military, hospital, or clinical services, the ECHO services, respite, ABA, parent-mediated programs, and other similar activities. There's a lot of services available to our beneficiaries, so we really want to bring them all together and work in collaboration with one another. They'll coordinate and participate in medical team conferences, and they'll help facilitate continuity of care when you move. So as I mentioned earlier, we do have a lot of movement. So if you're moving from one region to the other, we want it to be a seamless transition. Now they'll identify and facilitate connections with local community resources. So we've found a lot about support groups or police departments, fire departments, different things that are doing great things in their communities, and we want to link families with those resources. And then they'll also provide educational resources about autism spectrum disorder. So I mentioned on the previous slide that the ASN will develop and maintain that comprehensive care plan, or the CCP. This will be for the new beneficiaries that are assigned an ASN. So after a referral is submitted and the ASN makes contact, the CCP will begin development to include an intake process, a review of services, incorporation of all the outcome measures and the timelines, so it should be a much easier, streamlined process. If there's any PCS changes or timelines, those would also be documented. And there will be a discharge and transition plan. While I think the ASN is a wonderful addition, in healthcare, there's always a discharge plan. There's always something working towards discharge. And so we want that to be at the onset as well. So this CCP really allows for a more collaborative effort to be consistent and really focused on the beneficiary. The CCP is also different from the ABA treatment plan, and we've had a lot of questions about that come in. And so I just want to make sure that everybody is aware that this is incorporating everything into one big picture. So if you have speech therapy, physical therapy, ABA, all these different services, this is the one plan that's going to bring everything together. It'll also be updated every 6 months, which will be in line with the continued authorization of ABA services. And I want to make one more clarification remark about the CCP, because there was a typo in the manual that was published. The CCP it's completed within 90 days, but for that first authorization period, the beneficiary does not have to wait until that CCP is completed to begin ABA services. They can begin ABA services. We're not making you wait. Now, after that 90 days, if it's not complete, then the contractor will have to look at what's going on for that non-compliance. And it's over to you, Chris.
Excellent. So this is another exciting addition to the change, is our enhanced focus on parent and family support, resources, access, things that are really critical to a truly comprehensive program. Again, while the beneficiary is at the focus for the treatment towards the diagnosis of autism, the family is equally invested in a part of this success. And so with this manual change, beginning on October 1st, the contractors will have available on their website, so this is for everybody in the program, regardless of ASN status or not, that everybody will have access to a wide range of services. Things such as a parent toolkit. The contractors will develop a toolkit for the families to access. I know it says new to the ACD, but again, this is on the contractor website, and so it'll be targeted to the families coming into the program, but again, a resource for all families. The website will also highlight those local level resources that are that Amy mentioned on the previous slide. The ASN will help in the coordination of those activities, but for all families, they'll be available. And she mentioned a few, like the police department or the fire department, but there really are a wide range of clinical and non-clinical services available nationwide, both within the military health system or the Department of Defense, but also outside of the healthcare system. And we want to point families into those directions or those areas because they are of value. Various advocacy groups, various organizations have missions that really are meant to support. I know there's, for example, the ARC is a nationwide organization, and each of the states have different missions, but we want to draw people to those resources. So here in Northern Virginia, the ARC of Northern Virginia actually helps with things like special needs trusts or various support information, legal information, things like that. So while those may not necessarily be clinical services, those are absolutely available to the families, and we want to help connect. So that'll be available for you guys. The other one is a military installation opportunity. So the MWRs and other, Army Community Services, those organizations host various events too. Again, sometimes mostly non-clinical events, but resources for family or support groups or chat options, or even through Military One Source. I know it's mentioned the sub-bullet there, but these are great resources available, especially the military ones, without cost or without charge to the families. So again, connecting families to what's out there. The last one on this slide is about parent-mediated services. Those are another opportunity for families to receive other clinical types of services, and we want to draw attention to the wide range. Again, families' needs change over time, and we want to meet you where you are. So family-mediated programs is another type of clinical service available to families. Again, in addition to the speech and the OT and the PT and nutrition and mental health services, the parent-mediated services, again, are another option. There are some available within the military installations, but also those available in the private sector in the network. So again, we want to link families to everything that we can, both clinical and non-clinical. All right, now let's talk about outcome measures. Prior to the change, there were 3 outcome measures, and those are the first 3, the Vineland, the Social Responsiveness Scale, and the Pervasive Developmental Disorder Behavior Inventory. I'll talk about the parent stress measures in a second here, but those 3, the only things, again, that have changed there are that all 3 are required at baseline, and then the Vineland and the SRS is annual as opposed to every 2 years, and then the PDDBI it remains at the every 6-month interval. The addition is the parent stress measure, and they're 2 listed, but you only need to complete 1, and that's because they're age-based, not both of them all the time. But that requirement starts as of August 1st, and again, that's for ongoing authorizations or new authorizations issued after August 1st. I'll address some of the questions that we've received historically, or to date rather, about the parent stress measures. I want to clarify as much as I can about the data and the purpose. So as we think about a truly comprehensive program, like I mentioned, yes, the beneficiary is the perhaps the target for the treatment for autism, but the family, the siblings, all of those components really contribute to a truly comprehensive program. And what better way to help measure impact or reduction in parent stress, or are we providing enough services, or did we get the right services? You know, we want to be measuring this information. Some of the concern has been about what are we going to do with this information. Again, this is aggregate data so we, DHA, will never see individual beneficiary data. That's not our role. We don't have access to those health records. What should be happening is that your treating providers are looking at those scores and addressing those clinically as appropriate within their scope of practice. We are looking at the impact. What was the baseline? What was the impact? Is there something we need to change? Is there something we need to add, remove, augment, supplement in some way, clinical or non-clinical? And again, these are for making sure the family as a system is receiving the supports and needs to target, especially for the individual beneficiary, but for the family as a whole, reaching that maximum potential. 2 more bullets on here that I think I mentioned previously, that they're required at baseline and then those periodic intervals. And the measures can be completed by the variety of providers. The PDDBI is the only one that must be completed by the BCBA, and then you all as the parent, but the other 3 measures could be completed by a variety. And the contractors are responsible for identifying those providers and issuing those authorizations and ensuring that they are complete. I want to talk about some of the additions or expansions as well. So we added a couple of extra ADA service codes, which happen to be the group code. So group services for the beneficiary, but also group services for the families. There are coding guidance available to do these group ADA service sessions. The other one is the medical team conference, and that's why that's important, is it's giving your treating providers a mechanism to collaborate and to communicate on a regular basis. So if you happen to have, speech OT in your ADA provider, or maybe your specialist, or maybe there's the nutritionist, or, whoever is on your clinical team, those folks can get together and really collaborate and monitor that progress over that 6-month period. So we're really excited about having a mechanism for that. The other expansion is that we have retained the telehealth provision. So we know under COVID, which, the provision started a little over a year ago, we have retained that allowance, or received approval to continue the use of telehealth for the parent training sessions. There have been some other additions to the service requirements, like having families engage in a minimum of 6 sessions over a 6-month period, and those are completely clinically indicated. How long or how often families engage with their ADA provider is dependent on the treatment plan and what the goals are. But again, 6 touch points over the course of 6 months of the authorization period. And again, these changes take effect starting August 1st, so we still have a little bit of time. All right, so now we're going to talk a little bit about exclusions, the ones that really have kind of been of interest in the questions that have come into the ACD mailbox, but also that I know providers have sent us, families have sent us. So Amy, I'm going to have you start with the first one, and then I'll take over a few, and then we'll get back.
Okay. So the use of restraints, the first one here. This is not a new exclusion. Restraints have always been excluded under the ACD, but it's just a reminder because we've seen a lot of questions come in about it. And a restraint is really a high-risk intervention done in a setting where there's a nurse, a medical doctor, there's people in place or clinicians in place to ensure that the patient is safe, assessments are done. And in the outpatient setting, there's not always typically all those types of providers. So just to remind everybody, this is a high-risk intervention, and so it is excluded under the ACD. Back to you.
All right, great. So then I'm going to talk about the next two collectively, and then I'll talk about individual examples. So ADA services in the school setting, I think it's really important to remember what Amy said at the very beginning of the presentation, that the demonstration is authorized to render clinically necessary and appropriate ABA services for the core symptoms of autism. And what that means is the active delivery of ABA from the treatment plan that has been approved. And we have found that providers in the school or community settings have oftentimes been the role of a shadow support aid and not actively delivering ABA. Not to say that that support isn't necessary or isn't important or valuable, but I think we have to remember that we're talking about clinical delivery of services versus a non-clinical service. And so these clarifications are in place to ensure that, that those are followed. I want to reinforce that there still may be appropriate opportunities for clinically necessary services in both of those settings, but those just have to be clarified in the treatment plan and approved by the contractor for those to happen. Again, both in the school and in those certain community settings. I want to clarify, too, on activities of daily living. There's been, again, several questions about what the role of addressing ADLs, and again, it's the clinical delivery of ABA for the core symptoms of autism, which are the social communication deficits and the restrictive repetitive behavior deficits. We know that there are clinically appropriate targets for things that impact your child's ADLs, but those are things like the behavior that interferes, the behavior excess, or the deficit that interferes with the completion of, following tasks, or maybe there's a comprehension target where it's about understanding what the behavior deficit or excess is. And so those would be absolutely appropriate. But things like learning to use public transportation or things such as household chores or things like that, those in and of themselves are not the target for clinical ABA that's authorized under the ACD. Again, the behavior that impedes that would be appropriate. And then, Amy, I'll turn the lesson back to you for concurrent billing.
Okay, so concurrent billing. So there's some ABA or ABS codes, rather, that can be concurrently billed, but this is the exclusion part. So we're talking about codes that cannot be billed concurrently, and then also outside of ABA, such as if you had a speech therapy provider and an ABA provider conducting services at the exact same time and billing at the exact same time. That is not allowed, and that has always been excluded, but we've received quite a few questions about that. I would like to clarify, though, that if your child is going to a clinic that may have SPPT, OT, and ABA all in the same place, that the services can be done on the same day or billed for on the same day, just not at the same time, at the exact same time. So this was an additional contractor responsibility that will start on August 1st. Some of you may have experienced in the past where you're looking for an ABA provider and you may go on to the directory, or you may get a list of providers from a contractor saying, here's some options. We've put in a requirement for more of that work to be done before it gets to you. So the contractors will find a provider that has availability, and we're really pushing the access to care standard. So 28 days to obtain an assessment and 28 days from that assessment completion date to begin treatment. I will point out, though, if a military treatment facility or clinic directs the referral to a specific provider, or the family requests for a specific provider, but that doesn't always ensure access to care standards will be met. We understand that some families want a specific provider, and that is your choice. All right, so this is the phased implementation timeline I mentioned at the beginning of this presentation. We wanted to give a visual, kind of just where we were at from March 23rd, the publication date there, and then what you'll see over time through October 1st. So as you can see, most of the changes that will impact families start around that August 1st and go into October 1st. I won't read through each of this because I want to give time for questions, but this is a visual that will help you if you just want to glance back at it at a later time. So keeping up with TRICARE news and information, there's some links here. Just want to point out that this presentation was really a sneak peek, that many of the changes will be implemented in August and October, and so we'll be updating these websites in the coming weeks and months. If you need to contact your TRICARE contractor, these are the points of contact with links to their website.
Thank you. First question. So if my son was diagnosed a few years back, we were on a waiting list for ABA in our area. Do we have to get a new referral now? He is 14 now, so our ABA options are rather limited due to school hours.
I don't know if there's any more information that can be provided, but I think if you were first diagnosed before age 8, and there's an existing referral, or there was a referral, or there is, any sort of history there, absolutely, we want you to connect with a contractor. But if the current referral has expired, so the 2 years have been exceeded, then a new appointment would be necessary, but not again, I don't know about first diagnosis, but going back to get that updated referral or that next referral is the key to getting connected. And then once you have that referral in place, immediately contact the contractor. I, again, encourage you to actively engage whichever contractor you have to have them help you find an available provider.
I believe this is referencing the ABA as well. It says, for new patients, don't we have to complete it within the first year of treatment?
So I believe the question is referencing outcome measures. Maybe I might be making the wrong assumption, but there was, in the previous, before these changes, your baseline measure could be done within that first year. But going forward, we want to get a true baseline, and then depending on what the timelines for the different outcome measures are after that, whether it's 6 months or a year going forward. But as Dr. Viana mentioned earlier, we did open up to other providers and we got rid of the referral requirement so that those barriers are being removed.
Great. Another question that references referrals. Can you please clarify referral still needed versus a diagnosis? Some parents do not know the difference. Also, how will the parents be informed that they need the referral?
Great question. There is definitely confusion between what happens at that very first appointment and then what happens subsequently. So the very first time you get a diagnosis, if a referral is then triggered, that diagnosis with its complementary documentation, including the referral, gets sent to the contractor to issue the authorization. If ongoing services are required after that 2-year mark, that referral, just like any other ongoing care and any other benefit that requires a referral, would need to, you go back to the diagnosing provider, they all submit a new referral, but it's not a new diagnostic appointment. It is a, looking at, okay, you're requesting ongoing services. Let's look at your care over the last couple of years. How'd it go? What's working? What's not working? So that is for a referral for ongoing services, which is different from that initial diagnostic appointment. I think I answered all the parts.
Can you define outcome measures? Is that the result of the initial assessment?
So outcome measures, those are the assessments done. I believe we went over them briefly, but the PDDBI, the Vineland, the SRS, and that parent stress measure. When we reference outcome measures, it's one of those 4 assessments.
if I could add one more heads of clarification, that is different from the ABA assessment, which is done by the ABA provider, and that is maybe the ABA provider will administer something like the VB-MAP or the ABLES or another metric to look at some of those targeted skills in those various categories of development. Again, those are the ABA assessment, which leads to an ABA treatment plan, and then the outcome measures, which are those benchmarks of looking at progress over those intervals. Over.
Why would you not offer an ASN to all beneficiaries?
That's a great question. I think keeping in mind that this is a phased rolling out of a huge change, we are rolling out things like that too. We are rolling out the contractor's execution of these requirements. And so there are existing case management services that are readily available to all beneficiaries. Most often they are, if you get your care primarily through the network, it's through the contractors, but there are also case management services within the MTF. And then there are also non-clinical case management services available through other mechanisms. But again, we're rolling out these new requirements and phasing in as we progress through. So we can't start everything all at once. I think that would be overwhelming to everybody. And so as we roll them out, we will pick up those folks as they progress through.
A question along the same line. What qualifications does an ASN have?
As I mentioned earlier, you can pull up the qualifications right now. An ASN must hold a current valid unrestricted license, which includes they can be a registered nurse with case management experience, a clinical psychologist, a licensed clinical social worker, or other licensed mental health professionals who possess a certification in case management. The ASN must also have clinical experience in pediatrics, behavioral health, and or autism spectrum disorder, a healthcare environment, and proven care management experience. It's a wide range of clinical experience there. And as I mentioned previously, they can be supported by a non-clinical person as well.
Great. Another question, do you have to be enrolled in the Exceptional Family Member Program?
So for active duty family members, remember EFMP is a line program, a service program, and it's not a healthcare program. So that is separate and distinct from TRICARE, but there is that requirement for active duty families. Now, there are some exceptions, and I would have to defer to the policy specifically, but an example, like if it's a divorced family and the beneficiary is living with a non-active duty sponsor, not living with the sponsor, then there are exceptions. So again, those details are spelled out in the EFMP guidance, so I would point families to that language. But otherwise, remember, one of many benefits that EFMP offers is that it helps in that care coordination. So when you're PCS or, when the family gets new orders to go somewhere, there is a screening process for the families before they get assigned or before their orders are, I don't know if the word is confirmed, but that assignment process really helps facilitate and ensures families don't end up in places where there aren't services. And not just ABA, but all healthcare. That's the scope of the entire care that's required and what's available in the potential incoming location.
Thank you. I see that ABA in school settings are excluded. What does that mean for having ABA during summer programs?
If the program is outside of the academic environment, say like an after-school program, then it's possible that the ABA services could be approved if clinically appropriate, or if it is an academic environment, then it would fall back to the BCBA being authorized for a time-limited focused period of time.
Great. If a beneficiary is relocating from East Region to West Region, can an East Region PCM submit a referral for the West Region, or does the beneficiary need to wait until a new PCM is established in the West Region?
So I think that's a question that's further outside of the ACD, but we are working on how to streamline that process. I know that has been a question, again, not just about ABA, but all healthcare and how are we going to manage that. I don't want to mislead by saying we have it figured out, but that is the goal. The referral will stay active when if there is an existing referral, it'll stay active during that transition. But if a new referral is requested, we're working out how to make sure that those administrative issues, and think about it too, clinical oversight from the PCM, to make sure that somebody is actually responsible for that care. So we're working on that. We know we have to improve, and that is definitely on our radar.
Thank you. Will any of these changes that the DHA is making affect what ECHO covers as far as medical equipment, i.e. diapers, medical car seats, medical strollers, adaptive bikes, etc.?
So the changes to the ACD are outside of what would be covered under ECHO. So we are not changing anything that was just laid out.
Thank you. And you mentioned telehealth. Will this be available for ABA therapy sessions?
If you're meaning the one-to-one direct services by the behavior technician, that telehealth is not available under that service. It is available, though, under the parent session, as has been this last year. That's where the telehealth application is.
Okay. And then we signed up with ECHO in 2014 due to our autism diagnosis. Were we automatically enrolled in the ACD?
Not necessarily. You would need to have a referral put in for either ABA or ACD services, and then your contractor would start the process from there. But that's a great step if you're already enrolled in ECHO, because that seems to be the area that kind of gets held up a little bit. So great first step. And if you're interested, please contact your contractor.
Great information. What is considered a session for parent training? 1 unit, 1 hour, at our discretion?
Another great question. So that's clinically indicated, right? So a family may need more support from their BCBA at the beginning, so maybe more hours per, week or month, depending on where the family is. Or maybe a family is maybe only getting BCBA services, and so their touch point, maybe the family, or maybe you're transitioning out of BT services and are looking for parent guidance or support throughout as you transition out. So it really is clinically dependent. It could be 15 minutes once a week. It could be a couple hours once a week. It could be, a couple sessions, periodic sessions over the course of a month. So it really is dependent on the clinical need and the goals in the treatment plan.
Okay. Are ABA services in an after-school program considered a school setting? Can ABA services in an after-school program be authorized?
So again, if the after-school setting is a program where no academic services are being provided, then we would not consider it a school setting. And so if clinically appropriate, TRICARE ABA services may be authorized.
Is a daycare an approved community setting?
A daycare may be appropriate. Again, if they're clinically necessary and appropriate services identified in the treatment plan, then yes, it could be an appropriate setting for the ABA provider to target those core symptoms of autism.
And then we briefly talked about this, but it's an additional question. Who gets an ASN? If only new beneficiaries after October 1st, what kind of support do the existing beneficiaries receive?
Again, the new beneficiaries entering the ACD after October 1st will receive an ASN, but existing beneficiaries still have access to the case management services, and that could be through the contractor or maybe through the MTF. They also have EFMP support. Additionally, many new ASC resources will be available on the contractor's website, so that'll be something to look towards too. And that'll be available for all beneficiaries.
What will be done with the information for the parent stress measures?
as we were talking about the outcome measures, all of the outcome measures, their aggregate data is what we at DHA see. But at the individual level, your treating providers should be addressing some of those, or they should be incorporating the findings of those measures into the treatment plan. So the clinical outcomes. Regarding the parent stress measures in particular, again, you may have an ABA treatment goal, you may have a other services goals. That's the information where the outcomes or the results of those specific measures should be incorporated. Again, we at DHA won't see the individual name with the individual score. We get the aggregate data, and we're looking at change over time.
Can parents decline recommended adjunctive services, i.e. speech therapy, if the CCP or by ABA provider and still receive ABA, or will this negatively impact their continued participation?
We want the parents to be involved. So just because a service is recommended by referring provider, I guess doesn't mean it fits the family for whatever reason, but it's not going to negatively impact your continued participation. Maybe we might want to understand a little bit more as to, why, or maybe provide some educational resources about the other services. But if you decline, it doesn't mean you're not going to receive ABA.
And then last question, are ABA services in the community like the grocery store, library, park, or barbershop allowed?
So in general, remember the role of the ABA provider rendering clinically necessary and appropriate ABA is targeting those core symptoms, right? Active delivery of ABA. In general, some of these settings that you just listed, I believe you said the grocery store, the library, settings like that, you really have to think about what is happening in those settings. So if it's for the role of the support or a shadow aid, like going grocery shopping or something like that, that is not active delivery of ABA, those would not be approved goals. We're really looking for targeting those core symptoms. Remember the social communication and restrictive repetitive behaviors. So there may be settings where that could be approved if clinically appropriate, but without knowing the specifics, it would be hard to say yes or no blanketly.
Then apparently we have time for one more question. What is the rationale for no longer covering ABA services provided by a BT in the school setting?
So regarding the removal of BTs in the school setting, this is not a new requirement. It was more of a clarification. It was never the intent to reimburse for non-clinical or educational services. And as Dr. Deanna mentioned earlier, educational, academic, or vocational goals or targets have always been excluded from the ACD. So if the BT is acting as a school support, shadow, or aid, that's beyond the scope of ABA services covered and authorized under the ACD. So if the beneficiary does have educational or academic needs, then those should be addressed as non-clinical targets within their IEP process.
And then Dr. Serta and Dr. Deanna, I just wanted to give you a couple minutes for any closing thoughts or final thoughts for our audience today.
I just want to say thank you. We really appreciate the opportunity to get this information out and take some questions and provide updates as we, continue moving along through this timeline.
I just want to echo Dr. Serta's comments. Thank you all for dialing in, for participating. We're here to facilitate or answer any questions that you may have. Happy to keep answering. I would direct beneficiary-specific questions to your contractor because we do not have access to your particular health record at the DHA level. So please engage your contractor for specific questions. And thanks again for participating.
I just want to thank both of you, Dr. Serta and Dr. Deanna, for sharing your invaluable experience and expertise today. I'd also like to thank all of our attendees for participating in today's webinar. If we didn't answer your question today, please refer to the contact information in your copy of the webinar slide deck. And also you can find the answers to many questions about TRICARE on the TRICARE website at tricare.mil. This concludes today's webinar on Autism Care Demonstration Program Changes, an overview of what TRICARE beneficiaries need to know. Thank you.